A mechanically perfect hip fracture repair is routinely undone by the systemic hospital environment the patient enters next. For the elderly patient, the immediate threats do not stem from the orthopedic hardware. The threats are cascading physiological failures: postoperative urinary retention, catheter-associated urinary tract infections, delirium, and rapid nutritional decline. These complications share a common origin. They thrive in systems relying on fragmented, single-point medical interventions rather than continuous care. In practice, this fragmentation manifests as hard boundaries between clinical stages. The operating room resolves the fracture, the acute ward manages immediate vitals, and the outpatient community is left to handle physical recovery. But true recovery requires the exact opposite. It requires an unbroken sequence of bundled care, spanning all three environments. To achieve this, hospitals are constructing highly structured, evidence-based orthogeriatric clinical pathways designed to standardize every phase of the patient's recovery timeline. The surgeon repairs the bone. The clinical pathway determines if the patient ever walks out their front door again. This Prisma flowchart outlines a massive systematic review, tracking post-surgery interventions across all clinical settings. The researchers started with over 35,000 records and distilled them to 155 relevant articles. Crucially, the resulting data pool relies entirely on 109 high-quality randomized controlled trials, providing a rigorous empirical foundation for postoperative protocols. The second flow diagram charts a targeted review focusing on a critical, often overlooked blind spot in the acute phase: perioperative urinary catheterization. It narrows 674 records down to 16 specific procedural studies. By combining these two datasets, we can build a unified clinical system. We extract the macro strategy for long-term recovery from the 109 clinical trials, and we pull the acute micro-tactics directly from the targeted catheter studies. A functional postoperative system relies on exactly this balance: a standardized, predictable protocol that can algorithmically adapt to an individual patient's degree of frailty. This chart categorizes the most heavily researched interventions from those 109 randomized controlled trials. Two categories dominate the evidence base: rehabilitation with 39 trials and nutritional supplementation with 30. Yet the data reveals a critical limitation. When physical therapy or dietary support is confined exclusively to the inpatient stay, the benefits erode shortly after discharge. Isolated interventions fail to secure lasting functional outcomes. The solution is clinical bundling, the deliberate sequencing and overlapping of therapeutic interventions across the acute, subacute, and community settings. For instance, an effective bundle begins immediately following surgery on the acute ward with targeted inpatient nutritional supplementation. That nutritional baseline then directly supports the seamless handoff to outpatient care, where the patient undergoes progressive resistance training and long-term osteoporosis management. When nutrition and rehabilitation are synchronized across settings in this manner, the trials demonstrate measurable results. Hospital length of stay decreases, and the trajectory of physical recovery accelerates. Sustained functional independence relies entirely on this continuous structure. A protocol must survive the transition out of the hospital to be effective. However, reaching that subacute rehabilitation phase requires a patient who is physically mobile and entirely free of infection. That condition is often compromised on day one. Postoperative urinary retention, or POUR, presents an immediate physiological barrier. An inability to void the bladder prevents early ambulation and halts the rehabilitation clock before it even starts. This clinical pathway diagrams the proposed strategy to mitigate urinary retention. Immediately following surgery, the standard rationale dictates placing an indwelling catheter to monitor fluid output. This creates a clinical paradox. If left in place too long, the indwelling catheter acts as a primary vector for the exact complications it was inserted to prevent. The empirical threshold is stark. Maintaining an indwelling line beyond 24 to 48 hours doubles the risk of subsequent urinary retention and exponentially increases the incidence of catheter-associated urinary tract infections. To protect the patient's macro-rehabilitation timeline, the acute care team must treat the indwelling catheter as a strict 48-hour liability. It cannot remain in place simply for nursing convenience. In many hospitals, catheters remain past the 48-hour threshold primarily because their removal requires a passive wait for a physician's order. The structural solution is nurse-led protocols. These algorithms empower nursing staff to autonomously evaluate the patient and remove the catheter based on real-time physiological data, bypassing the physician bottleneck. The objective data point driving this is the bedside bladder scan. If the post-removal scan reveals a residual volume exceeding 200 milliliters, the protocol dictates the use of targeted intermittent catheterization rather than reverting to a permanent indwelling line. Intermittent catheterization proves clinically superior because it mimics natural voiding cycles and significantly reduces the risk of biofilm-associated bacterial colonization. We can observe the real-world efficacy of this logic in specific clinical initiatives, such as the widely implemented Pull the Foley program. By structuring removal criteria, these programs achieved a 50. The elderly hip fracture population contains an incredibly wide spectrum of baseline health. This bottom section demonstrates how a comprehensive geriatric assessment acts as a sorting mechanism, stratifying incoming patients into specialized tracks based on specific vulnerabilities. For the robust patient, the clinical mandate is clear: prioritize immediate catheter removal and push for early mobilization. Conversely, the frail patient requires an adapted pathway built on conservative interventions and proactive monitoring to catch delirium early. In frail patients, severe constipation predicts unsuccessful catheter removal, so their urinary protocol must be strictly paired with a proactive bowel regimen. The most complex algorithmic adaptation is required for patients presenting with dementia. Cognitive impairment actively masks the standard symptoms of urinary retention and infection. To secure this pathway, clinical staff and caregivers must shift their assessment entirely to interpreting nonverbal cues of physiological distress. Standardizing care across a ward means establishing a baseline and then providing a rigorous, algorithmic adaptation to the patient's individual frailty. When we zoom out, the integrated orthogeriatric clinical pathway comes into focus. It links the strict 48-hour acute urinary protocol directly into the subacute multidisciplinary rehabilitation and outpatient nutritional tracks. This sequenced bundled model systematically neutralizes the primary red zone complications, urinary retention, severe infections, and delirium that routinely plague fragmented hospital care. The clinical philosophy is straightforward: strictly reducing unnecessary medicalization during the acute inpatient phase creates the biological prerequisite for aggressive rehabilitation in the weeks that follow. This is why the 48-hour catheter removal threshold must operate as a non-negotiable key performance indicator for the surgical ward. And it is why structured cross-specialty handoffs are mandatory to maintain bone density and muscle mass long after the patient goes home. Mastering the mechanics of this complex multi-stage clinical pathway stands as the defining challenge of modern geriatric orthopedics. Surviving the fracture is merely the baseline of surgical competence. It is the flawless execution of a bundled, algorithmically adapted pathway that actually